provided care to more than 100 Medicare patients in the measurement year. That has significantly changed for this year, and it's going to knock out, as I mentioned, about 500,000 providers nationwide. So this year, that low volume threshold triples the Medicare Part B allowable charge, so now it's greater than $90,000 in Medicare Part B billings, and they have to provide care to more than 200 Medicare patients. You can check that program eligibility. There's a link on this slide right here. Go to that site, and there's a nice lookup tool there. It's by NPI, so you punch in your provider's NPI, and it's going to show you everywhere that NPI is billing. So if your clinicians are working at multiple TINs that are not yours, it's still going to show that information there, but you can ignore any of that information except for the tax IDs where that provider works for you. If you do not meet that the low volume threshold, you can still report. CMS encourages you to report. They want your data anyway, but just know that voluntary reporters, that data will still be publicly available on the Physician Compare website. So anyone who participates in the MIPS program is going to see their data publicly available on the Physician Compare website. One reason why somebody might want to voluntarily report is because of that public posting that's going to happen. You might be a rock star provider who's demonstrating incredible quality and low cost, but you're a low volume provider, so you don't have to participate. But knowing that patients are now going to be in a position to shop around based on quality and cost, and you might want to get your data on that Physician Compare website so that patients can see that you're an awesome provider, and they might choose you over the practice down the street who is providing lower quality care or higher cost care. Who's exempt? So looking at the flip side, we just looked at those that kind of major hurdle to get into the program. So who's exempt? Who does not have to participate again this year? If you're newly enrolled in Medicare, so any of your providers who just got credentialed to participate with Medicare this calendar year, they are exempt. So again, they can optionally participate, but they won't get any of the financial benefits of the program. Next year, the following performance year, as long as they meet that low volume threshold, they must participate. And then I mentioned that low volume threshold. If you are below that low volume threshold, you are exempt. So just to clarify, to get into the program, both of the qualifiers of the low volume threshold have to be true. You must provide more than $90,000 a year in Medicare Part B allowable charges, and you must see more than 200 patients in that measurement year. If either one of those conditions are not true, one or the other or both, then you are exempt from participating. And then that third box just makes reference to that other path. As I mentioned in one of the first slides, we've got those two paths of the QPP, the MIPS track and the advanced APM track. If you are in an advanced APM, which I don't think any of you are on here on this call, if you're in that advanced APM track, you're sort of excluded from MIPS, although that's a bit of a misnomer as well. Non-patient facing providers get some special considerations in the MIPS track, such as not needing to participate in the promoting interoperability performance category. So there's no change in how they're designating non-patient facing providers. You can meet it at the individual level if you have less than or equal to 100 patient-facing encounters in the measurement period. Groups can also be determined as non-patient-facing groups. And again, if you have any questions on that, go to that eligibility lookup tool that I mentioned for the low volume threshold, and it's going to provide all of the special status information there as well. So you don't have to guess if you're non-patient-facing or CMS sees you as non-patient-facing. Just go to that eligibility lookup tool, and they will tell you. So again, no change there. There is this new concept of a virtual group. I don't believe anyone on the call is in a virtual group. I think we only had one virtual group form in Michigan, and I have yet to encounter any of those providers. If you are in a virtual group, I'd love to talk to you offline, so please give me a call. You have my contact information at the end, because I just want to talk through the virtual group concept with you a little bit. I'll talk about what that is in just a moment as well. Other special statuses, we didn't see any changes to these from year 1 to year 2, but the small practice definition is more relevant this year because of a small practice bonus that is now added for those of you that have 15 or fewer billing clinicians. So it goes by not just by eligible clinicians, meaning those that can participate in the MIPS track. When they are defining a small practice, CMS looks at the number of billing NPIs. So if you are submitting claims under your tax ID, if you are putting 15 or fewer NPIs on your claims in total, you are deemed a small practice. Again, if you are questioning whether CMS sees you as a small practice or not, go to that same eligibility lookup tool and it will deem you either a small practice or not. We sometimes encounter practices that have 30 NPIs, but they're not putting all of those NPIs on their Medicare claims. So it just looks at those NPIs that are billing Medicare. And then no change in the rural and health professional shortage area definition either. We did see a significant or a relevant change to the performance periods when we look across the 4 performance categories. Last year, your quality performance category was looking at a minimum of 90 days of data, so you could shift that reporting period to kind of maximize your quality score. There was a good reason to do that. It might have made a significant difference in your quality performance category score. This year, it is a full 12 months of data. So we are into our 9th month already of quality data being captured that must be submitted to fully participate in the program. The cost category was not used. We got feedback. So if you participated in the program last year, your MIPS feedback report included some cost data so that you can see if they did incorporate this category into your MIPS final score, you get an idea of how that provider would have scored. This year, cost is being used. It's at 10%, so it's just a small chunk of your MIPS final score, but just know that they are using 12 months of data. It's all off claims, though. There's nothing you have to submit on that one. I'll talk about that in just a little bit more in a moment as well. Improvement activities, it's the same as last year, no change in that performance period. You had to attest that you had those improvement activities implemented for a minimum of 90 days in calendar year 2017, and is exactly the same this year. It is a minimum of 90 days in 2018. And then the same thing with promoting interoperability. It was known as ACI, or Advancing Care Information, last year, and it was a minimum of a 90-day reporting period, much like we've seen over and over again with meaningful use. You can report anywhere from 90 to 365 days of data last year, and it's the same again this year. So it's a minimum of 90 days. Sometimes it makes sense to extend that reporting period to 100 or 101, or maybe the full 365 days. So you've got your choice there, and I encourage you to run those MIPS dashboard reports in this category to find that reporting period that's going to maximize this performance category for you. There's a few different ways that you can report in the quality payment program or in the MIPS track. You can report as an individual. So each NPI and tax ID combination is seen as a separate program entity. That's a major change from what we all worked with under meaningful use. So in this program, you only have to worry about what's happening under your tax ID. So if you have a provider that is working moonlighting at urgent care or working at another practice for a different organization, you shouldn't care what's happening at that other organization. They will worry about MIPS under their TIN. You only have to worry about MIPS under your TIN. So you can report as an individual, meaning just that provider's data is submitted to CMS. They will receive a MIPS final score that will hopefully give you a positive boost in that reimbursement rate. And each one of your individual providers could end up with a different, or probably most likely would end up with a different reimbursement rate under the individual reporting option. You could also band together and report as a group. As a group, you're taking any 2 or more clinicians under that same tax ID and consolidating their data and submitting a single set of data for those 4 performance categories to CMS. In that case, when you group report, just know that you are not just submitting your MDs, DOs, NPs, PAs, and just those 5 provider types that we mentioned early on. If you group report, you have to include all of the data for all of the providers in your practice, whether they are MIPS providers or not. So if you've got a clinical social worker or a psychologist or anyone that's in your practice, when you group report, you are going to consolidate everybody's data, including those folks that aren't going to be affected financially. So this is caused lots of confusion with group reporting there. So I just want to make that clear. If you opt for this, and it often makes a lot of sense to group report, and I'm going to talk through that on the next slide, kind of making that decision. I'll give you some best practice advice there. But if you choose group reporting, you have to include data from all clinicians, all billing clinicians in that practice. And then there's the caveat 2B there as an APM entity. If you are in an ACO, you are automatically locked into group reporting. You've got no options there. You are reporting at the ACO level, or what's known as an alternative payment model. That's what APM stands for. So if you're in an ACO, you are not individually reporting. You've got no option to individually report. You are locked into group reporting at the ACO level. New for this year, we've got this concept of the virtual group. The best way to describe a virtual group is it's sort of like a mini ACO, much like the way the ACOs work, where they have providers at different organizations all banding together to provide that care as a group and are kind of sharing in those savings. A virtual group in this program acts in much the same way, where you can have solo practitioners or groups of 10 or fewer clinicians who come together virtually and form this, what is sort of a mini ACO, where they submit all of their data as that virtual group, and then their adjustments, they all get the same final score, and those reimbursement rates are all adjusted collectively as well. There is an approval or an application process that takes place prior to the program year. So the only way to participate in a virtual group in 2018 is if that virtual group formed in Q4 of last year. And so on October 1st, we're going to see the 2019 virtual group application period open up again. So for anyone wanting to form a virtual group for 2019, you have to go through an approval process with CMS in the Q4 of this year. So one of the big challenges for folks is figuring out, should we participate at the group level or at the individual level? So there's some things you want to look at, and then on the next slide I'm going to get to really some best practice way to go about this. So one way that you might look at it is consider those differences in your Medicare volume relative to your MIPS scores. So that can make a huge difference in choosing to go individual versus group. So if your top performers, meaning looking at their scores individually in this program, if those top performers also bill the most Medicare in your practice, group reporting could hurt your bottom line because the top performer scores, when aggregated at the group level, are going to drop more. So in that instance, group reporting is bad. So look at MIPS scores A on this little rudimentary graph I have here. We've got those top performers, provider A and B, are also getting ridiculously high MIPS scores. In this scenario, group reporting is bad because the group score is going to be 55.6 in this model. And so you wouldn't want to have your top performers who are billing the majority of your Medicare get dragged down. You want your top performers to get the best score you can. So in option A, group reporting is a really bad idea. But if your lower performers are billing the most Medicare, group reporting group reporting would be really advantageous in that for the opposite reason, because those low performers, you want them to get the best group score. So individually reporting those in column B, you know, column A or provider A billing $500,000 a year gets on their own, if you individually reported, would only get a MIPS score of 10. That's not going to boost their reimbursement rate very much, or really at all. Where if you group reported, that top provider, his score is now a 55.6. It's a much better score. It's going to have a greater advantage there on that reimbursement rate. So in column B, if that's the way your practice looks, group reporting is a very good idea. But there's another caveat here that kind of changes this all up. We know from the group participation resource on the CMS website, look at that, and there's a screenshot of one little box there. Look at that second paragraph. It says a MIPS eligible clinician participating via a group will get the group score. However, if the same MIPS eligible clinician also submits individual level data, CMS will use the higher of the two final scores for that clinician. So with this in mind, the best overall strategy for a lot of groups then is always group report, with one small caveat there that could negate this. It's unless including those non-eligible clinician provider types negatively affects your score. So remember, I mentioned if you group report, you have to include data from all of your clinicians, whether they are one of those 5 provider types or not. So if by doing that, you're going to get a much worse group score, that's going to throw this off. We don't necessarily see that very often, but it could certainly be the case. So take a look at that caveat there. So that aside, always group report. Then, if your eligible clinicians can report at the individual level, again, there's some work you have to do here to see if this is a good strategy, but we often see this, that if you can report at the individual level and that individual provider's MIPS final score is better than the group score, also report that clinician's individual data to CMS. So with this strategy, those lower performers are raised by the higher group score, and your higher performers are then not negatively affected by your lower performers, because CMS is going to use their better individual score instead of that lower group score. So it's a little loophole you can use here. It's totally legal, but it's a strategy to group report, but then so you're going to maximize your overall MIPS final scores, which then translates to the best Medicare reimbursement rates you can get. So if you can do this, absolutely this should be your strategy when you're kind of deciding to group report versus individual. For a lot of groups, they're doing both to take advantage of this. Any questions on that? All right. Next, we're going to get into the mess of submission mechanisms. So there's a lot of different ways to get the data to CMS. For the most part, it doesn't, for 3 of the categories, the method you choose to get that data to CMS doesn't really matter. So as you can see in the quality category, if you are an individual, if you're submitting individual data, you can use a qualified clinical data registry, a qualified registry. You can report directly through your EHR. You can use claims-based reporting. What's kind of missing off this is manual attestation. There is you can log into the QPP attestation portal and upload your quality data file there. It's essentially the same as EHR reporting, where what's called a QRDA3 file is just uploaded to CMS. So your EHR can send it directly to CMS on your behalf. They might charge you for that. You can also just upload that file at the QPP MIPS attestation portal as well. So we've got some different options if you're at the group level there under the quality reporting. Cost is all off the administrative claims, so you're not submitting anything. CMS is just looking at your Medicare claims and scoring you on the cost category. Improvement activities, also you've got some choices there. And then it still says advancing care information on this slide. It should, I got to switch this one over to PI or promoting interoperability, but you got some options there. One thing we didn't see them open up for year 2, they have it proposed for year 3, is the use of multiple submission mechanisms per performance category. So what that means is going from performance category to performance category, you can choose a different submission mechanism. So you can report your quality data through a registry, you can manually attest your improvement activities, and you could have your EHR submit your promoting interoperability for you. So you can choose a different submission mechanism in between each submission, in each performance category, but within a single performance category, you can only choose one mechanism. For the most part, that doesn't hurt anybody. In the quality category, it most definitely does. We were really hoping CMS was going to open up the use of multiple submission mechanisms within a single category for this year. They have punted that now to next year. We do see that coming next year, and it will make quality reporting a lot easier for you. It'll also allow you to maximize to get a better quality score, and I'll talk about why in just a moment. So we're going to get into each of those 4 performance categories now, and I'll talk about each of them at kind of a high level, and then some tips and tricks if I have them for you on what to do here. So in the quality performance category, we see a small change in the weight to the final score. So if your MIPS final score is 100%, 50% of that is coming from your quality category. So out of the 4 performance categories, quality is by far the most important because it's half of your MIPS final score. So if you are limited in your resources and you can't focus on everything, you want to focus on quality. So you get the biggest bang for your buck here. Last year, it was worth 60% of the final score. This year, it's worth 50%. That other 10% moved over to the cost category. The same 271-ish measures that were available to choose from last year are the same as this year. In order to fully participate in this category, you're going to select 6 quality measures to report on. One of them must be an outcome measure or a high priority measure. They do offer some specialty-specific sets of measures. We rarely see those specialty measure sets work better than just going through the list of 271 and choosing your measures individually, but that's your choice. You can just go off of those specialty measure sets if you'd like. We did see a small change in data completeness. It's a concept I need you to be aware of. I'll explain what data completeness is. I'll use the example of NQF 59. I think it's CMS 122, I think. It's the main A1C outcome measure. A lot of folks, it's probably one of the most reported measures. That's why I like to use this as an example. So we'll look at what data completeness means in terms of that measure. So that measure looks at the A1C results of all of your diagnosed diabetics. What data completeness says is you must, if you choose to report on that measure, you must apply that measure to a certain percentage of your patients. So with NQF 59, you have to apply that measure and report on at least 60% of your diagnosed diabetics. If you report on fewer than that, you're going to fail data completeness, and the most you can get is a single point for that measure, regardless of what your quality score actually shows. If you fail data completeness, you're going to get 1 point. If you're a small practice, they've raised that floor a little bit, so if you violate data completeness, you're going to get 3 points instead of 1. The most you can get is 10. So really, if you're reporting through your EHR, so you're just downloading that quality data file out of your EHR, your data completeness is 100%, because your EHR is going to automatically apply that measure to every single patient that it can. So your data completeness is where we see this come into play really is under claims-based reporting, because when you're claims-based reporting, you're entering that G code on the claims of your diabetic patients, you could game the system, and we see this happen a lot, where if you have an out-of-control diabetic, so their A1C is terrible, you could just conveniently forget to put that G code, that quality code, on that claim. So CMS allows a little bit of the gaming. We're seeing this data completeness rise, that percentage rise. Last year it was 50%, now it's 60%. We're going to see that go up to about 80% in future years. So you be able to game the system less and less, but you could forget to put that quality code on 40% of your diagnosed diabetics, which would significantly boost your quality score. But there's some caveats there too, relative to the benchmarks, and I'll talk about that in a moment as well. So data completeness is now 60%. So there are no changes with some of the other scoring components, as long as the quality measure has a benchmark set. That's how you're scored. CMS is going to determine whether you get anywhere from 3 to 7 points on that quality measure based on comparing your provider's score to the benchmark on that particular measure. So the worst you can get, as long as the quality measure has a benchmark set for it, not all of them do, but most of them do now, there's a 3-point floor. If it doesn't have a benchmark or you don't meet the case minimum, in order to be reliably scored on that measure, you have to have at least 20 in your denominator. So if you've got just 1 out of 1 patient, the most you're going to get for that score or for that quality measure is 3 points. CMS wants your data, so to fully participate, you could maximize this category with just the 6 measures, but CMS wants all the data they can get from you. So they reward you by over-reporting. If you report additional high-priority measures, you can get an additional 10% in this performance category. It's a great way to boost your score. You also get a bonus for using an end-to-end electronic reporting method. So those submission methods I talked about, where you can submit through claims or through your EHR or through a registry, claims-based reporting would not earn you this bonus, this end-to-end electronic reporting. But if you are submitting your data electronically, let's say you are uploading that QRDA file at the QPP portal, your EHR is sending it, it's going to be deemed one of those end-to-end electronic reporting mechanisms, and you will earn up to an additional 10% in this category as well. So it's another nice way to get a better quality score. So when you're looking to choose those measures, really ideally you're going to look at your patient population to guide that measure selection. You want to pick, as best you can, you want to pick clinically relevant measures. That's not always possible, especially when you get into specialists. It can be very difficult to find 6 clinically relevant measures. So as the best you can, you want to match up those measures to what's really important to your practice and what aligns with those practice goals. As I mentioned early on, specialty measure sets often are not your best option. When we analyze the data that we've collected through our scoring tool called MIPS, very rarely do we see the specialty measure set being the way to go. We see folks scoring much better in this category when they go off that beaten path and just choose the best 6 measures they can out of that much bigger pool. Registries have this option to create their own measures as well. So those clinical the QCDRs, the clinical qualified clinical data registries, they can get their own custom measures approved by CMS to be used in this program. This year they're known as non-MIPS measures. They're going to call them registry measures next year. We find this being a great option for specialists who have difficulty finding 6 clinically relevant measures out of the big pool. Look at the registries who are offering non-MIPS measures. There are registries out there for a lot of different specialties, and they've gone off the beaten path and gotten their own custom measures approved for use. So that's a good way to get a better quality score for your specialists. So if you're looking at those scores and it's demonstrating terrible quality, just know that that doesn't mean your provider's providing terrible quality. We see a wide range of issues with these quality measure scores. Oftentimes, the vendors have things messed up. It drives us crazy, but it happens time and time again. Unfortunately, you can't trust your EHR vendor to program these correctly. We see all kinds of issues. They often rely on you to configure these quality measures, which is something to me is just absolutely ludicrous. But we see code mapping is one of the common problems, where you could run that NQF59, that A1C outcome measure, and it could show really terrible quality. But really what's the problem is there's a code that's not mapped properly behind the scenes, where your EHR is just not measuring all of the patients because of some crazy configuration issue. So we also see data entry issues. It could be actual quality issues where your diabetics are just out of control, and you're capturing the data correctly, and you just got to work on those patients to get better A1C values. But I can't tell you how many times we see what looks like a low quality score. The provider's actually doing great, and their patients have great outcomes, and it's really a configuration issue. So you really, once you pick your 6 quality measures, I hate to say it, but don't trust your vendor to have this calculating correctly. You've got to really run those. The best thing you can do is run those quality measures and then drill down. Look at the denominators that your EHR is capturing, and then look at who's in that numerator. But more importantly, look at who is not in that numerator and find out why. If they're being seen in the denominator but not the numerator, make sure that that's accurate. It could just be a configuration issue. You map a single code in the background, and all of a sudden, all of those denominators are also now showing up in the numerators. So you got to drill down to make sure. I wish that wasn't the case. The vendors are getting better, but we see it time and time again. The vendors just have them all messed up. Data submission options matter under quality. This is a huge difference because of those benchmarks. You also want to look at the cost of the submission mechanism. Some of them are very, very costly. To go through a registry could be more expensive than just getting downloading a file from your vendor and uploading that. I already mentioned that there are more registry options in terms of measures. Not every one of the quality measures can be submitted by every submission mechanism. So it adds another ridiculous layer of complexity to that quality measure selection process. You might find 6 clinically relevant quality measures, but then when you look at the options for submission, you might find that 5 of them can be reported via claims, but only 1, but then your 6th one can only be reported via EHR. So you're kind of back to the drawing board because you have to find 6 measures that can all be submitted through the same submission mechanism. Adds another layer of complexity. I'm going to get deeper into that, into the benchmarks caveat in just a moment. Also the topped-up measures caveat. I've got some slides here coming up next that kind of talk about what that is and what you have to be careful of. So that qualifier, these quality scores vary by submission mechanism. I can't stress this enough. We've got there's a whole lot of numbers on this. I've tried to kind of color code this a little bit, but hopefully you can kind of follow along. This is looking at Measure ID 110, the preventative care and screening for influenza immunization. It's looking at 3 different submission mechanisms, and you can see how much that score can change. So at the very top, we have a math formula there. The performance rate on this theoretical provider is 62. So let's look at the 3 different ways you can submit this quality measure. So in green, we have the claims-based submission mechanism. You can run that quality score through the formula and see that the total points awarded is 5.96 for a performance rate of 62. So on that, if you submitted through your claims, you got a performance rate of 62. That 62 is going to translate to 5.96 out of a possible 10 points. If you were to submit that exact same information, so that exact same performance rate of 62, through your EHR, which means you are either the EHR is submitting that quality file on your behalf, or you're getting that quality file, you're downloading it yourself from your EHR and simply uploading it to CMS. That exact same quality score of 62 is going to give you 8.9 points out of 10. It's a significant difference. That can make a wide-ranging difference in your final MIPS score. Or through the registry, the ones in blue, same performance rate running through that same formula is going to give you 6.64 points, so kind of in between the two. So as you can see, that submission mechanism is a huge component because the exact same performance rate can give you wide-ranging points, and it's because of the benchmarks. Each submission mechanism has its own benchmark. So depending on how you submit that data, that score is compared to the benchmark for that submission mechanism. The benchmarks are set off of the historical performance rates that have been reported on that particular measure. And because CMS sees such a wide-ranging difference between the submission mechanisms, each mechanism gets its own benchmark. And claims is the worst because of that gaming of the system that we see. Providers use claims-based reporting to get a better quality score because, like the example I used with NQF 59, they can just conveniently forget, in quotes, to submit that quality score on their out-of-control A1Cs. So while you can game the system and on the surface appear to get a better performance rate, really in this program, it's going to hurt you by doing that because you're going to be compared against a much worse benchmark. Any questions on that? It can be kind of confusing, but hopefully that makes sense for you. So we'll talk about the topped-out measures then. This is something else you need to be aware of. There's topped-out, and now this concept of topped-out capped for this year also. We didn't have topped-out capped last year, so this is new to us. Measures that have been topped out, and what topped out means is there's no meaningful distinctions between the lowest and the highest performers on this, meaning really everybody is scoring really, really high on that particular measure. If everybody is scoring really high, this measure can be deemed topped out. If it's topped out, it's really hard to get a good score. What could appear to be a great score really isn't a good score because everybody is scoring so well on that particular measure. Measures that have been topped out for at least 2 consecutive years now become topped out capped. And in a topped out capped measure, instead of earning a maximum of 10 points, the most you can get on that measure is 7 points. So if you happen to select all topped out capped measures, you're going to significantly hamper your quality performance category score. It's going to significantly lower your MIPS final score. So you might have to pick those topped out capped measures because those are the only ones that are clinically relevant. But for the most part, steering clear of those topped out capped measures makes a lot of sense. So these are the 6 topped out capped measures that we have this year. So there's only 6 out of that long list of 271, but we are going to see the topped out capped explode. We're going to see this list significantly increase in coming years because a lot of those quality measures have been topped out for more than 1 year. I don't know how many are going to be on this list next year, but it's going to be significant. So just know if you are choosing any of these 6 measures this calendar year for reporting, the most you can get is 7 points. So you also want to be wary of using the topped out quality measures. If you're curious on if the measures you're choosing are topped out or not, you want to grab the benchmark, the quality benchmarks file on the qpp.cms.gov website. That'll come up again on a future slide, but qpp.cms.gov. That's the main QPP website. You want to navigate to the resource library. You want to get to the 2018 resources. There's a file there called Quality Benchmarks. Grab that file, and it's a big Excel file, but it will list which of those measures are topped out or not. So a lot of measures are topped out, but they're not yet topped out capped. And so you want to be wary of those, because even though they're not capped, you could still get 10 points. It's really hard to get 10 points. Look at that at CMS 68 there, where claims-based reporting is topped out at decile 5. So what would appear to be a really high performance rate at 99.99%, I mean, you are doing phenomenally well, but because it's topped out, you can't get all of the points. If you miss one patient that's falling short on that one claim, and you're going to drop all the way from 10 points all the way down into the 5 range. So just because it's not yet capped, you might still find yourself essentially capped because because you can't get to that perfect performance. So be wary of those. You could significantly hurt your quality score by choosing too many topped out measures. The issue is the majority of the quality measures out there are actually topped out. I think like 200 out of the 271 are at or near topped out status. So even if it's not topped out, you could find your scoring options are limited. Look at that bottom box for CMS 2. So under claims-based reporting, this is a measure that's nearing topped out status, where it hasn't yet been deemed topped out. But if you're claims-based reporting, even if you're at nearly perfect performance, you're still only going to get 7 points for that measure. And you'd have to have absolutely perfect performance to get those 10 points. So this is really difficult to get through. I know there's so many facets to this quality reporting, between finding clinically relevant, can they meet my submission mechanisms, is it topped out? This is really where you need to focus the most of your attention, is ensuring that you have chosen the right quality measures that are going to get you the best quality category score. I can't stress that enough. We're all limited with our time and resources, so because of that, you can't focus on everything. You really need to focus on quality and make sure that you're maximizing this. Any questions on that? All right, we're going to move into cost. So the cost performance category, this year there are only 2 cost measures that are going to be used. Last year you got feedback on the cost category for these 2 measures. This year the cost category is worth a meager 10% of your MIPS final score. There are 2 measures that they're going to be using this year. It's the Medicare spending per beneficiary, or called the MSPB, and the total per capita cost measure, or the TPCC. Those are the only 2 that are being used. There are minimum thresholds for that. So if you don't have enough patients that can be attributed to these cost measures, you won't get scored in this. And I think we're going to see that quite a bit, where a lot of providers CMS can't score them on either one of these measures. If that does happen, where neither one of these cost measures is applicable to your provider or your group, then that 10% is going to shift back to quality. So instead of quality being worth 50%, it's going to be worth 60% again this year. It is all claims-based reporting, as I mentioned already, so you're not submitting anything additional for this category. So really there's not a lot you need to do in this category, other than just ensure that you and your providers are not hurting yourselves by unnecessary costs and unnecessary spending. You know, before you order that CT, you want to make sure that the patient didn't have a CT done last week. That is more than relevant still this week. Don't just order a CT every time you want a CT result. You know, you need to be really cost conscious and make sure that you're not costing Medicare more than is necessary. You want to at least be in the middle of the road pack, where you're at least costing Medicare as much as the provider sitting next to you. If you are overspending, you're ordering tests, you're bringing patients in that don't have to be seen, you're costing too much, you're going to end up hurting yourself here. CMS is going to bring probably 10 or more episode-based measures in next year, so there's going to be a lot more to the cost category. The big issue we have here is CMS they are the kings at flying the plane while they're still building it. So you guys are at a disadvantage in the cost category. CMS is not able to provide you with the level of detail that you need to really assess at the provider level how your clinicians are doing. You can get some you can get some, look at those 2017 MIPS feedback reports, and if your providers could be scored in the cost category, there's some good information there. But CMS is woefully lacking. They've promised us that it's coming. I think we're going to see the feedback coming or the data coming out of the cost for the cost category. We'll see that expand significantly. But at this time, there's not a whole lot you have to look at. If you participated in the PQRS program in the past, I would encourage you to look at the feedback reports that came out of that program. They're called the QRURs, or the Quality Resource and Use Reports. Go to the QualityNet website where you were doing that PQRS reporting, grab those feedback reports. They go up through the 2016 program year and really drill down into cost there. That's really your best option at this point for getting good provider level or group level cost data. Whatever was happening in 2016 is probably happening now in 2018 still. Providers don't tend to shift very much in the cost category. So if they were a high cost provider in 2016, they're probably a high cost provider in 2018 as well. Let's see, I might have covered all of this. Administrative claims, so you're not submitting. So you are, the benchmarks that they're going to set in this category, in the quality category, they're looking at past performance to set those benchmarks. It's different for the cost category. I think this is another reason why CMS is really struggling to give you the data you need. It's because they are assessing cost within the same performance year. So they're not using prior years to set those benchmarks. They're going to set those benchmarks within this year also. I mentioned it's that performance is the average of those two measures. If only one of those two cost measures is applicable to your provider or your group, that will serve as your cost performance category score. And if neither of those cost measures, which we're going to see that happen quite a bit, if neither one of them is applicable, that 10% is going to shift back over to the quality category. So it's worth 10% this year, but we're going to see it increase over time until it is worth 30% of the MIPS final score. At that point, it will be on par with quality. When we get to the end weights, as it were, quality will be worth 30. Cost will also be worth 30%. So it's going to be on par eventually, but it'll be a few years before it reaches 30% of your score. Hopefully by that time, CMS is also able to give you guys the cost level data you need. So it's the average of those two. The reason we'll see it not be applicable to providers is really how these measures are calculated. There's a patient attribution that's in there, which is really confusing to understand, and it's impossible to figure out which Medicare patients have been associated or been attributed to which providers. It's another place CMS is woefully lacking. They are hearing daily from providers who are screaming for the attributions, and CMS is just not able to provide it at this time. To be scored in the MSPB, you need to have 35 episodes attributed to your provider or your group. So while you might have some beneficiaries kind of assigned to you, if you don't have 35 or more, you won't be scored. On the TPCC, it's 20 or more episodes. And if only one can be scored, as I mentioned, that'll serve it. And I already talked about it being shifted back to quality if neither one of those work for you. Again, you can get that feedback from your 2017 reports. I talked about the QRURs. One of the best things you can do, perhaps, in terms of affecting your cost category is to double dip by choosing quality measures that also get at cost. A lot of them kind of touch on cost as well. A lot of process measures can help with your cost level data as well. So double dip by ensuring that your quality measures that you choose also affect your cost performance category. And that last bullet, CMS would kick me if they hear me say this, but really in all actuality, of the 4 performance categories, cost should be the least of your concerns if you're just looking at that MIPS final score. because with it only worth 10% this year, a ridiculously good shift of 10%, which is really unheard of. I mentioned already that we don't see much change in a provider's cost measurement going from one year to the next. If you were able to lower those costs by 10% on those measures, which would be almost unheard of, we rarely would see your cost category measures shift by 10%. But if you were able to shift it by 10%, it would only shift your MIPS final score by a single point, which is negligible. That's gonna mean almost nothing in terms of your Medicare reimbursement rate. So until it's worth more, and really we know more, until CMS is really able to give us the cost level data we need to affect this category, your improvement efforts may be focused in those areas of greater impact, particularly quality. So don't worry too much about this, because it's not going to make too much of a difference. You know, cost is cost right now. We do see one scoring improvement. This is new. So it was going to be two. We were going to see a scoring improvement bonus added for quality and for the cost performance categories. The Bipartisan Budget Act that was passed earlier this year wiped out the cost one, at least for now. But just know that this year, CMS is going to look at the quality category score for last year that you submitted, and they're going to look at your quality cost category score for this year. And if you have improved, if that category score has improved, you could earn up to an additional 10 percentage points in the quality performance category. It doesn't matter if you've changed measures, so it doesn't look measure by measure to see those improvements. It looks at all six plus measures, whatever that cost, whatever your quality category score was. It's going to look at potentially increasing or giving you that bonus if this year's quality score is better. All right, improvement activities. It is worth 15% of the final score. It's the same weight that it had last year. We had 94, I think, activities to choose from last year. We now have 112, so they've added some activities to choose from. As last year, all of the activities are either medium weight or high weight activities. The medium weight ones are worth 10 points. The high weight ones are worth 20 points. However, if you are in a small practice, those are doubled. So if you have 15 or fewer billing clinicians, you are deemed a small practice, and those weights are doubled. So the medium weight are now worth 20 points, and the high weight are worth 40 points. You maximize this category when you reach 40 points. So a small practice could report on a single high weight activity, and they would get the full points in this performance category. They'll get that full 15% towards their final score. A simple yes, this is the honor system with this category here. So you are just attesting to the fact that you had that improvement activity implemented in your practice for a minimum of 90 days this calendar year. So you can just go to the QPP attestation website and say yes to one or two or more of those activities, and you can maximize this category. They made a significant change to some terminology relevant to the patient-centered medical homes. There is a caveat within this category that if you are a PCMH provider, you automatically get full credit in this category, so there's nothing more you have to do. The fact that you are a PCMH provider means that you already get those 40 points. So last year, it was anyone who was certified PCMH could get that automatic full credit in this category. They've changed the terminology now so that it's recognized. The reason they did that is in terms of the PCMH neighbor program, the specialist program, because the specialty PCMH side doesn't certify those providers, you're just recognized. Those folks could not take that credit last year. But what worries me here, I've had this discussion with a number of folks, is the proof. Blue Cross Blue Shield and their neighbor program, apparently there's no certification, there's no proof, there's no good way that you can prove to CMS that you're a PCMHN or neighbor practice. So I really just be cautious there. It's not a popular guidance, but my audit-proof best practice guidance for the PCMH neighbor people is don't take the free pass. Find a couple of activities in that list of 112 and just attest to those anyway. While you should get that full credit because you're a PCMHN practice, you're a neighbor practice, the fact that Blue Cross Blue Shield is woefully lacking in providing you the proof you're going to need if you get audited 6 years from now, it just makes me really cautious, really wary that those neighbor practices are going to fail audits down the road. Because the improvement activities, that list of 112 activities, was built off of the PCMH model, if you are truly a PCMH office, even a PCMH neighbor office, it should be very easy to find a couple of activities in that list of 112 that you already have implemented. So if that's the case, to be audit proof here, don't take the free pass. Just attest to those activities, because you'd hate to lose some money down the road and fail an audit down the road because you took the free pass as opposed to just attesting to those activities. That's the best advice I can give you. Let's see, they've added some additional activities and changes to the existing activities, including credit for the appropriate use criteria. So there's some additional activities that have been added there. They have continued, at least for this year, we're going to see this bonus get taken away for next year by the looks of it. But they've made this weird connection between what was the advancing care information performance category. It's now the promoting interoperability category. There are, I think, 18 or 19 improvement activities that are kind of tied to the EHR, meaning the way that you would meet that activity is by leveraging the technology of your EHR. If you attest to one of those improvement activities, it's going to give you a 10% bonus under the promoting interoperability category. So those are still in place. We saw that weird connection last year, this weird bonus. We see it again this year. But it looks like it's going to go away for next year. For group reporting, if you are opting to that group reporting submission option, only one of the clinicians within the TIN has to be doing that improvement activity in order for the whole tax ID for that whole group to take that credit for it. So everybody gets the points for that if one clinician is doing it. The same sort of thing happens under virtual group. You only need a single clinician, and they continue to allow that simple attestation. This is kind of the easiest one to get through. You're just attesting yes, although you do need to make sure that you are keeping auditable proof of that improvement activity. It is the honor system, but they're going to test your honor if you get audited. So make sure that you can back up your claim that you did that improvement activity this year. All right, moving on to promoting interoperability. It's worth 25% again this year. Again, we see it comprised of the base score, the performance score, and the bonus score. I'm going to break down what that is and show you some scoring on the next slides. It's really focused on promoting the patient engagement and the electronic exchange of EHR, the kind of the hardest measure to get through in this. There's two measure sets available. I'm going to talk about what those are based on which version of the EHR you're using, whether it's a 2014 or a 2015. You can use either one this year. Next year, that is not the case. You have to be on 2015 technology next year. This year, you can still use your 2014 or your 2015 or a combination of them. However, if you are on your 2015 technology and you use let's call them stage 3 or the regular PI measures, and I'll show you what those are, you can get a 10% bonus in this category. The same exclusions we saw last year on 2 of the PI measures, e-prescribing and the health information exchange, those are there again this year. There's no change to the base score requirements. For performance, they really did non-immunizing providers a disservice last year with the way they had the public health measure spelled out. They have fixed that deficiency for this year. So the public health objective is scored a little bit differently, where last year you got 10 points for for connecting with MICR, and then you got some bonus points for connecting with other registries. Now you get that 10 points for being connected to any of those public health registries, and then you can get bonus points. So they've stopped penalizing those non-immunizing providers this year. And again, I already mentioned you get then, if you're connected to 2 registries, you get an additional 5% bonus for that second registry. And already talked about that link back to the improvement activities to get that 10% bonus. Automatic reweighting is, again, relevant this year. What that means is certain providers don't have to participate in this program, in this performance category, if they don't want to. So there is automatic reweighting, and then there is also reweighting through an application. So under the automatic reweighting, hospital-based clinicians, ASC providers, nurse practitioners, PAs, CNSs, and CRNAs, CMS is not expecting promoting interoperability data from those providers. So you could kind of take a free pass on that. What happens is that 25% is going to shift over to quality. So if you allow this automatic reweighting to stay in place, your quality score is going to jump from being 50% of your MIPS final score all the way to 75% of your MIPS final score. So CMS is not expecting information on this category from those providers. You can override that reweighting though and submit data anyway. Oftentimes it makes good sense to do so because it is often easier to capture those 25 points or that 25% through this category than it is through the quality category. So it's yet another layer of complexity. If you've got reweighted providers, you need to decide whether you want to allow that automatic reweighting to happen on these clinicians, or if it makes sense to override that. Submit PI data anyway on your nurse practitioners and PAs because in the end, they're going to get a better MIPS final score. Other providers, or for other reasons, you can apply for reweighting through an approved application. That application is now available on the QPP website. This is new for this year. They're also now giving small practices a pass. So if you have 15 or fewer billing clinicians in your tax ID, and let's say you don't have an EHR yet, you don't get penalized this year. You could apply for that hardship exception. You could just tell CMS, hey, we're a small practice. We're not going to participate in PI this year. That will get approved just based on the number of clinicians in your practice, and then CMS is going to shift that weight over to the quality category, so that quality is worth 75 instead of 50%. There are some other reasons as well: significant hardship exceptions, decertification. If your EHR has lost their certification, you don't get docked in this category. You could just take a free pass and avoid the PI category altogether. They've also extended the deadline for submitting that application. Last year, you had to submit it, I think, by October 1st. Now we have until the end of the year, and it'll be the case in future years as well. So at any point throughout the year, you can apply for that pass. They've also revised the definition of a hospital-based clinician. All of this is accounted for in that eligibility tool that you saw a link to early on. If you're wondering if your group or your providers are listed or if they're defined as hospital-based, just go to that eligibility tool, but just know that they have increased the places of service that you're billing to in that definition of a hospital-based. So they are now also looking at the off-campus outpatient hospital place of service. Place of service 19 is now also included. All right, we're going to break down the promoting interoperability performance category. It's got 3 different components that give you that category score. You've got the base score that's worth 50% of, or 50 points. So that's half of your performance category score comes from that base score. And I'll talk about what that is on the next slide. Then we have that performance category, or the performance score, that you can make up to an additional 90 points. There are those ways I've already mentioned to get the bonus points you could get the additional public health reporting that gives you 5%. You could attest to those improvement activities that are linked back to your EHR and get the additional 10% there. And then you get the those three components get added together to get you a category score. If you score at least 100 points, you have maximized this. So as you can see, there's 155 points possible, but you only need 100 points in order to get a max category score here. And I'll show you how that works as well. So under the base score, these you have, I also mentioned early on, there are two measure sets. On the left side of this, the 2018 PI transition objectives. These correlate back to the modified stage 2 meaningful use measures. The other objectives, what are deemed kind of the regular PI objectives, translate, or they correlate back to the stage 3 meaningful use objectives. You have your option to choose either one this year. Even if you are on 2015 technology, if you don't want to transition to those and start reporting on stage 3 measures yet, you don't have to. Everybody has that option to use the transition objectives. So in the base score, to get any PI score at all, you have to meet base. If you fall short on your base score, you're going to get a big whopping 0 in this category. So in the base score, you have to do one of everything. So you have to make sure that you are sending one electronic prescription. It doesn't matter if your denominator is 1 million. As long as you have sent one script electronically, you've met the base score objective. Health information exchange. This is the one that is very difficult to do well in for a variety of reasons. But to meet the base score, you have to send that summary of care electronically to one next provider of care. There is an exclusion for both of these measures. So if you are not ERXing at all and you have written fewer than 100 scripts in the reporting period, you could take the exclusion. We don't see very many providers still needing to do that. We see a whole lot of providers that need to take the exclusion for health information exchange. Again, that is very difficult to do. You have to send one electronically to get the base score unless you have transitioned fewer than 100 patients out of your care. If you have fewer than 100 patients, you could then take the exclusion, which would allow you to send none of them electronically and still meet that base score. You have to do your security risk analysis. That's never going away. You've got to do one of those every year, at least update your previous year's SRA. So you've got to do that, make sure you're doing that every year. And you have to provide patient access to one patient. So this is the patient portal measure. It's measure 1 of the patient portal objective. This is when you are offering your patient portal to as many of your patients as possible. As long as you offer it to a single patient, you're going to meet that base score. So it's one of everything gets you that base score. Performance score then circles back to some of those measures and really measures your overall performance in those ones and a bunch of others to see how well you're utilizing your EHR. So you can get up to an additional 90 points in this objective, or in this component in the performance score. So each one of those measures, for instance, the provide patient access, the more patients you offer your patient portal to, the more points you're going to get in your performance score. Most of the objectives are worth 10 points. 2 of them in the transition objectives are worth 20 points. It is that patient portal measure and the health information exchange measure. So while you can take a pass on it and not work on it, it's really not advisable. You really need to be doing the best you can on that HIE measure, because it is worth quite a bit in your overall objectives as well. It's also worth 20 points. So the better you do on each one of these measures, the more points you get. Big difference to meaningful use, you had those minimum thresholds you had to overcome in order to get to meet that objective. It's not the case in PI scoring. So there's no minimum threshold. The great thing about that is a 1 out of 1 is 100%. So if you have one patient that you transition to another provider of care and you send that electronically, you could get the full 20 points there.
That we have to attest to.
Is there a question?
Next year.
I'm sorry, I didn't hear that question.
Oh, I'm sorry. I should have been on mute.
Okay, no problem. So yeah, the better you do on each one of these measures, the the better you're going to do in that performance score. You want to get the best you can here. So how is that performance rate calculated? This is taken out of one of CMS's, one of their resources. You just take that performance rate, you take your numerator and denominator, turn it into a percentage, and then based on that performance rate, it's going to give you anywhere from 1 to 10 points on that measure. So in this very rudimentary example at the bottom, if a MIPS eligible clinician submits a numerator and denominator of 85 over 100 for the patient-specific education measure, their performance rate would be 85%, and then they would earn 9 out of the 10 percentage points for that measure. You can actually earn, there's deciles there, so it's not necessarily the 9, it could be like the 9.5 instead. So I'm going to break it down here and kind of show you how this would shake out on a theoretical provider. So this is looking at the base score. So this theoretical provider is doing phenomenally well in terms of ERX, which we see most of the time, doing also really well on providing their patient portal to their patients, missed very few, only 3 patients didn't get offered their patient portal, is doing an unusually well on the HIE measure. They were able to electronically send that summary of care to 21 out of the 83 of their patients, and they did their SRA. So in terms of the base score, they did really well. They only had to do 1. So you only needed 1 ERX, 1 VDT, 1 HIE, and it's a yes, no. Either you did or you didn't do the SRA. So this provider more than earned their base score, did really well. So moving on to performance category scoring then, this is a pretty average meaningful user. They're doing unusually well in the HIE, got a decile score of 3. It's one of the ones worth 20%, so they got 6 points for that measure. BDT, doing really well, got the full 20%. Patient portal usage, they're 43% of their patients are actually using their patient portal, so they got 5 points there. Patient education, they're doing really well, which we see most of the time. MedRec, we see folks doing really, really well on that as well. That's just normal course of business. You're always reconciling those medications against the next provider of care for those incoming patients, so get 10% there. Secure messaging, they're doing terrible, which again is pretty common. We don't see secure messaging used probably as much as it should be. There's a whole host of reasons why, many of them valid, many of them just their providers or staff are just not using that functionality. So this theoretical provider got a whopping 1 point for that. And their public health reporting. So they're actively engaged with MICR or the dental registry or their cancer registry. There's a lot of different registries. Any one of them is going to earn you that 10%. So the total performance score is a 62 out of 90. So middle of the road, not doing terrible, but not doing spectacular either. Again, this is what we often see. They might be meeting those meaningful use measures in terms of that program, being a decent meaningful user. Looking at the bonus then, this provider is connected to a second registry, so they get that additional public health reporting, but they did not get the 10% bonus by attesting to one of those 19 improvement activities that's tied to their EHR, which again, very, very common. So looking at this example scoring at the bottom then, they got their 50% base score, they got 62 out of 90 on their performance score, and they got a third of the potential bonus score. Oftentimes, we don't see the bonus needed at all. So don't really focus on that because a lot of times it's just not needed. And this example provider is a good example. It's a mediocre performer, but their total PI score is 117. You're capped on 100%. As soon as you get that 100% or 100 points, you've earned the maximum 25 PI points. So again, if you can't focus on everything, focus on quality because that's where we see the biggest bang for the buck. Work on those quality measures because oftentimes, especially if your providers have been meaningful users in the past, even a mediocre meaningful user is going to get 23, 24, 25 points in this category. So don't kill yourself necessarily getting that HIE measure up and running because you might not even need it to get a perfect score here. So focus on quality if you can't focus on everything. We did see a change in the performance threshold. An increase in performance threshold here. Last year, that minimum threshold to avoid a penalty was a whopping 3 points. This year, it is 15 points, so you have to earn at least 15 points in your MIPS final score in order to avoid a penalty this year. The exceptional performer bonus is set at 70 points, so ideally, you want to get at least 70 points in your MIPS final score. That's going to mean a much better Medicare reimbursement rate because you will be deemed an exceptional performer, and there's some additional monies that get split up for those folks. If you fall below that 15 points, if you don't earn that minimum 15 points, you could see as much as a 5% decrease in your Medicare reimbursements a couple years from now. So there's always a 2-year lag between the performance year and the payment year. So last year's performance is going to affect your 2019 payments. This year's performance is going to affect your 2020 payments. So if you get a perfect score, we could see as much as a 5% gain. That's the glass ceiling that's sort of impossible to reach right now. But the low end of that is absolutely reachable. So if you don't participate and you are required to, you are going to take a 5% penalty in 2020. Last year, we had this concept of pick your pace, where you could do a minimum amount of information or a minimum amount of participation and avoid that penalty. While CMS hasn't formalized those pick your pace options this year, you still kind of have those options available. There is some minimum things you can do to at least fly under the radar and get those 15 points. You don't have to fully participate in all of the performance categories to get 15 points. There's several different ways that you can go about it. I've got 4 options listed there at the bottom. You could report all of the required improvement activities. That could be it. That's all you have to do, because it's worth 15% of your MIPS final score. If you maximize that improvement activities, if you're a small practice, you could attest to a single high weight activity. You don't have to worry about a penalty. No matter what else happens, you're good to go on that penalty. You could meet the base score for PI, which is going to give you half of those points, 12.5, and you could submit a single quality measure that meets that data completeness threshold that I talked about. That would give you 2.5 points. That gets you exactly at that 15-point mark. You could meet that PI base score, getting those 12.5 points, and you could submit a single medium weight activity that's going to get you at least those 7.5, double if you're a small practice. So that's another way to just get over that 15-point threshold. Or you could just participate in the quality category, and you could submit those 6 quality measures, and as long as they all meet data completeness criteria, you're going to get 2.5 points for all 6 of them. That's going to just get you into that threshold of 15. So while we don't have those formalized pick your pace options, you really don't have to participate fully. I really encourage it though. Try and do the best you can while the performance threshold is so low. It's not going to be low for much longer, folks. Next year, it is probably going to jump to 30 points. And then from there, it's most likely going to be the average performance from the prior year. And while you might be taking the easy way out, the practice down the street is not. So most providers are trying to do the best they can in this program, which means when the performance rate a couple years from now is probably going to jump into the 70s, maybe the 60s. My guess, my feeling, and based on where we see folks, a lot of folks are in the 60 to 70 range, and the average performance is in the high 60s last year. This year, it's going to be even more. Next year, it's going to be even more. So when that threshold starts to become the average performance of all the previous folks, if you've been taking the easy way out, you are going to find that it is very difficult to reach that minimum performance, and you're probably going to take a pay cut. So if you can, fully participate, do the best you can. While it may not net you a great reimbursement rate, it's going to set you up the best you can for those future years when that bar is raised significantly. I know I'm getting low on time, and I want to make sure there's at least a few minutes left for any questions at the end. So I'm not going to go through this slide. This just shows you kind of where last year to this year fell relative to that MIPS final score, anywhere from 0 points to 100 points, and you can see what that means in terms of that payment adjustment for 2020. This is the calculating the final score. These are the weights for these activities this year. Quality, just to kind of recap, is worth most of it, so focus on quality if you can. Cost is 10, improvement activities 15, and promoting interoperability 25%. There's a new complex patient bonus. This is new for this year. If you have a lot of complex patients as measured by the HCC risk score, CMS is going to add up to an additional 5 bonus points. CMS recognizes that providers that are taking care of highly complex patients are at somewhat of a disadvantage, so they've tried to level the playing field here. Just note that caveat at the bottom. You don't automatically get that bonus unless you also participate in the quality PI or IA categories. There's also a new small practice bonus. So if you do have 15 or fewer billing clinicians, as long as you participate in one of the other categories, quality PI or IA, cost does not count there because we're all going to get assessed on cost. As long as you are a small practice and partially participate in one of those other categories, CMS is going to boost your MIPS final score by another 5 points. Last slide is, if you are struggling at all with this program on your own, please stop. There is free help available to absolutely everybody who wants it. So if you are a small practice, if you have 15 or fewer billing clinicians, you can come to us. The website is at the bottom there, qppresourcecenter.org. Click the Join Now button, connect with us. It's free of charge. I highly recommend it. We've tried to enhance what CMS has done by really providing these customized project plans to kind of navigate this really complex program. We kind of will help you through it every step of the way, feeding you a project plan so you can shave off all the questions and confusion that doesn't apply to you, and take a more streamlined approach to participating in the program. The other great thing that this provides for you is access to our proprietary scoring tool, MIPScast. So quality category is difficult to understand. MIPScast makes it a no-brainer. We can help you select the best quality scores just by uploading a quality file. You download your QRDA, that quality file that you can all get from your vendor, upload it through our tool. Our tool is going to analyze it for you and tell you, use these 6 measures and use these ones for your bonuses. So it also gives you that kind of sandbox to play in. MIPScast is great for a sandbox. It allows you to manipulate your scores, choose between individual reporting and group reporting, and really get through all the caveats I've been talking to you about for the past hour and a half, so that you can just ensure that when it comes time to a test, you are giving CMS the best data possible to get that best MIPS final score. So this is all free of charge for anyone who is a small practice. So I encourage you to connect with us through the QPP Resource Center. If you are a large practice, there is free resources for you as well. If anyone is familiar with the organization MPRO here in Michigan, they are servicing the large practices. If you're not sure how you get your free support, just come to me. You can ping me, you can go through the Resource Center, and we're going to help you. If you don't qualify for our free service, we're going to get you in touch with MPRO to get your questions answered and get the support you need. I'm also happy to help determine that, as well as answer every question you can throw at me. So the QPP Resource Center has a whole group of folks like myself who know this program inside and out and can guide you. You can pummel us with every question you can think of. If anyone has pinged the QPP help desk from CMS, you've probably been left wondering about these folks. You don't always get the best guidance through the QPP resource or through the CMS's QPP help desk. You won't find that same issue with us. So please come to us with your questions. We would be happy to help. If you've got any questions, I'm happy to take any now as we try to wrap up here. You can ping me afterward, shoot me an email, call me on the phone, or get to us through the QPP Resource Center. We'd be happy to help you. Any questions I can answer? All right. Well, I hope this has been educational for you guys. I know there is a ridiculous amount of complexity to it. That is why we are here. So hopefully I've cleared up some confusion for you, helped to steer you in the right direction for how to maximize those MIPS scores this year. And again, if we can answer any questions going forward, please don't hesitate. This is what we are here for. This is what CMS is paying us to do. They want us to help you. So please use us to your advantage.
Well, great. That was an excellent presentation, Bruce. And on behalf of NPO, I just want to thank you for your time today.
You're very welcome.
All right. Thanks, everyone.
All right. Take care.
Yeah.